This is lecture 6 in the series, When the Image Lies, Artifact, Exposure Errors and Quality Assurance. Welcome to RadSound FRCR Physics. You remember our approach from patient to science signal, detector, image, acquisition, and softening. So this is the 6th lecture in the series, When the Image Lies. So no everything you have seen on the image will be a pathology. So something might be on the image, but still it's not pathology. So what happened when the image lies? So that a bit of many things. You can say it is just X-ray, the exposure it is hectic because I see okay, it is grainy image because a line there. Artefact now is blurring, pathology are not the same. Okay. So what happened when the image lies? Artifact. So every artifact has an origin somewhere in the imaging chain. Mostly, as you can remember, we started with the source. So there could be a lot of things that happens as a result of source. So to output, prior exposure, factors of filtration, abnormal collimation from the patient that could be possible. Maybe motion artifact, maybe mispositioning, maybe clothing, something per external, maybe body habitus of the patient, because maybe you can say a cleft on the side of the patient. You may assume that could be pneumothorax. And at the same time, as a signal path from the patient, the remnant beam, that could be from the remnant beam scatter and create abnormality, gap abnormality, geometric abnormality. Sometimes the issues could be due to detector. The problems might arise from the detector. So defect on the image plate, defect inside or on the detector itself could lead to abnormality, create abnormal finding, abnormal appearance on the image plate. So see a plate that could be DR, dead pixel, failure of calibration or abnormal calibration. And sometimes all might be perfect, but the problem will arise from the processing. So that could be histogram, lack of table, algorithm abnormality, cropping, and sometimes everything will be perfect for problems from the quality assurance because we're not following the quality assurance as it should be. That part of parameters that must be monitored annually, some of them every 2 years, some of them every 6 months. So failure to do quality assurance might lead to artifacts. What's quality assurance? Quality assurance are the thing that we doing as preventive measures to prevent overexposure or abnormal imaging and to get better quality image from the source to the patient signal detector image. Each stage can introduce errors that will be assumed as pathology. So understand the origin and preventive measure and the importance of understanding or differentiating artifact from the or tracing the artifact. Find the artifact with the artifacts that might arise from the source. We can have underexposure. In underexposure, the appearance will be a grainy image, noisy image, poor or low contrast visibility. Any subtle legends hidden in noise cannot be seen. So insufficient MAs muscle could be the possible cause because the body part is very large and the MA is very less. Or KPP is too low for the exposure because if the KPP is too low for the exposure, the beam would be less intense. The quality of the beam would be less because under exposure we got image what is noisy, grainy. We cannot make diagnosis. So in such situation, how can we prevent it? But prevention mostly proper audit exposure indices. So audit the exposure indices routinely, train staff on technique selection, calibrate AEC, and also remedy can increase MA, KB pay appropriately, monitor and verify the AEC chamber selection before starting. Sometimes the image will not be under, it will be overexposure. In overexposure, detector saturation becomes a very easy earlier data clipped irreversibly does creep in detail system because you cannot understand whether it is over or under exposure. So there will be dust creep, high dose, despite the exposure is high, but we cannot understand in digital system. Image looks acceptable, but still overexposed. Acceptable brightness is not equals to the correct exposure. So overexposure, the image will become look acceptable sometimes, especially in the digital system, and still dose to the patient is very high. So what could be the remedy? Mostly you reduce the MA appropriately to the level of that exam check whether the exposure index and deviation index for every exposure, okay, whether it is negative, what negative, that's underexposure, or to positive overexposure, it should be around 0 for perfect better imaging. Talking about the problems, artifacts that might arise from the source. As the beam started to move, what will happen? That could be failure of collimation. So the area you have selected, a bit less area, you say, that there's the whole area. So you've got area, this is the needed field in green, and this is the irradiated area. So what's wrong here? Field too wide, increase the color, reduce contrast, because color increase in scatter will lead to most scatter reaching the competing with the primary beam, remnant beam, and most scatter reaching the detector, causing more noise, okay, reduce contrast, reduction in the contrast, unnecessary irradiation of tissue, increase dose to the patient, electronic cropping, doing electronic cropping to hide such irradiation. Really, it will hide the field, but just does remain constant because you have already captured. So cropping hides the field, but does not reduce the dose. The remedy for collimation failure is to collimate as tightly as possible to a region of interest before exposure. Electronic cropping cannot undo what we haven't done before, so you should start by doing proper collimation. So prevention of such error in department, training on correct exposure, correct collimation practice, light field verification before exposure. Mostly you can just verify the area before exposing the patient, and quality assurance also will prevent such. So we still moving from the source. Let's say what will happen if we get problems or artifact at the patient level. So at the patient level, there'll be a lot of things that might happen. So we have a patient, and the beam is not in the patient body. So during patient might forgot something on the chest, and the patient is capturing chest X-ray. You'll see a lot of things. So jewelry will appear on that chest X-ray. It may hide something in the upper or superior mediastinum, and part of the chest also. You can say ECG leads, tube going in, AT the endotracheal tube, part of the NG2, part of the tube coming from the brain to descending to the tummy, the abdomen. It's a clothing buttons, sometimes hair braids, oxygen tubing, monitoring wires, other all of them might cause artifacts. They are all originated, they are associated with the patient. So such external objects can mimic lines to pathology. For instance, if we have linear pathology on the X-ray, so the linear tube can hide it. A skin fold can mimic a pneumothorax also. But how can we differentiate? Mostly skin fold can we say the line extend beyond lung, neutral pleural edge, marking mostly the marking of the lines and marking visual beyond line, mostly for the skin fold. For the pneumothorax, visual pleural line, no marking beyond, etc. And they mostly follows the lung contour. Rotation can create a pulse asymmetry and appearance. All poor positioning or poor rotation can lead to distortion. Distorted pelvic asymmetry you might think there is a bit maybe fracture. All these are artifacts that might arise from the patient because of the excellent something patient wearing from the inside tools coming to the patient, abnormal position, abnormal rotation. All of them might arise from the patient. So how can we get rid of such issues? Mostly to get rid of this issue, proper communication. Communicate with the patient well. Remove all non-essential objects from the field before exposure. If you seen on image, note as artifact, you can write it, you can mark it. Standard patient preparation checklist, okay, gown, sometimes patient may wear gown, policy, so that you can have such policy. Patient comes, remove their dressing, wear something, they go. But this may consume time also, and also finances. So clear the verbal instruction. Take proper inspiration. For instance, just say what would say in X-ray. So in X-ray, even the X-ray. So taking proper inspiration, and the patient to not move, to hold breath, etc. So proper communication can minimize such artifacts, and proper positioning. Still inside the patient. and we're getting some errors or artifacts because of abnormal position, abnormal movement, external thing at the parents. So, sometimes patient movement, as I mentioned, respiratory, cardiac, and others. Bowel, sometimes you can give some drugs that may minimize the bowel motion. And pediatrics, feed and calm. Just feed the baby prior for 30 minutes. Feed the baby and capture it. Something that will take only 2 minutes. Feed the baby and capture, or can let the mom be nearby the baby. Some respiratory people, proper communication, breath holding, telling the patient to hold breath for few seconds. Cardiac muscle, you can use ECG gating to prevent that. So, tremors, sometimes I can give some anxiolytic medication so that I can get better image. I try to minimize the timing. The less time and the better management of the time you do during the capturing, the less will be the motion artifact. So the worst artifact, the motion artifact, will gonna be with the more time. So the exposure at the time increases, there are gonna be more motion and sharpness. Something that might happen in the motion and sharpness is what we call blurry edge. Sometimes as we get such a blurry edge, we try to create something which we call edge enhancement or halos. The edges appear sharper, but details still lost because the edge are not part of the image, are not part of the data that we have already captured. So it will give a false sense of improved resolution. But remember, those such resolution does not mean like it does not are not true resolution. They are not part of the image. They're not part of the body. So what usually happen, excessive unsharp mask or something that happened at the edge of the images, the best way to prevent such occurrence is set appropriate enhancement parameters per exam. Do not apply enhancement to compensate for motion blurring at the edge because such will give false impression and it may hide a bit of pathology at the edge of the body part you captured. And still, that enhancement does not mean better resolution. So now get our beam taking data from the patient going to the detector. That's the remnant beam. Or say the beam that is coming out of the patient taking the information. So what could be the issues here? Mostly, if you can remember, as we follow our own photon, we used to place some certain thing to prevent or reduce scatter formation. So in such, we use grid, air gap, grid, geometric. So now, what about grid? There will be a lot of artifacts related to grid, which we call grid cutoff. What will happen? Normally, off-center grid, the grid that is not at central part, you will call it to asymmetric cutoff, one side darker than the other, and the cause mostly because the tube not centered over the focus grid. So in the off center, the tube is not centered over the focused grid. So lateral offset of central ray remedy. The best way to prevent these off center issues is to reposition tube to the center of the grid and repeat the exposure. So the patient get double exposure. And the prevent such thing before prior to capturing patient, align the two grid center line. They must be aligned as we shown in this example. The tube is coming, so this is center line of the grid. So align them. They shouldn't take just off center. This is supposed to be center. You take it away. The tube is not central. What about off focus grid? Off focus grid error. The peripheral part is the off focus. So the peripheral part, peripheral exposure become lost. Why? Because the source to image distance is outside the focal range of the focus grid. So the central part will have adequate, but the edges will become underexposed. Why? Because the beam coming will be absorbed, will not pass to reach the peripheral part. They will be absorbed by the light. So what about up-level grid? The up-level grid error, there will be generalized reduction in exposure across the entire image. So the off level is the only grid error that will affect generalized area. That will be generalized reduction in exposure across the entire image. This has happened because tube angled across perpendicular to the grid, like it is perpendicular to the grid, but the lines rather than along them. So they are more toward the line. No, the tube is angled toward the line, not toward the center of the grid also. What about upside down? Upside down, mostly there will be severe bilateral cutoff, only narrow central strip adequately exposed, unmistakable pattern. So mostly, the cause is a focused grid inserted upside down. So just like focused grid, they are inserted upside down. So instead of going like this way, okay, so they are inserted upside down. So only the narrow area, only the center part, the central part would have adequate exposure. So what could be the remedy? Remove and correctly orient the grid. That is, take it and rotate it so that to get better exposure and repeat the exposure. But the problem with such is that grid on itself increases the dose to the patient. So if you do get such a mistake also, there will be another dose additional to the patient. Issues with the grid is what we call moire pattern. This is mostly wavy interference like pattern. So the bit line, you can see them along this, okay, affecting part or all the entire image. The cause is due to aliasing between stationary grid line frequency and digital detector pixel sampling frequency. So remedy, instead of using stationary, we use oscillating backy grid, that's rotating moving grid, okay. Apply grid separation software if available, reprocess the image, and prevent such moire lines. You just start match grid frequency to detector. You shouldn't use a frequency, the detector which has less frequency than the grid, because such is going to lead to aliasing. Remember the aliasing, because if the frequency is less than twice the optimal frequency that we have to take, so definitely there will be aliasing. So you should start check everything. That's an important quality assurance to prevent such occurrence. So we are still moving along with our signal. We have done with the sources, patient artifacts related to the patient, and now we're going to detector. What could be the abnormality related to detector? The most common is we have let us take the CR and also the DR detector types. You have a CR. Mostly for the CR, we can have scratch image plate. That's a scratch will appear on the image. You can see a scratchy. Sometimes cracked plate, double exposure, light exposure, delayed readout can lead to turn out, or the image might fade away because of delayed readout, incomplete erasure of the image exposure to the white light. So after the readout, if you didn't do a better eraser of the image, that would be a ghost image also. Then what about you can say example of double exposure, you can say another one is part of the body, another part, so double image on the same plate. This is not a diagnostic value actually. We have to repeat the exposure. And then when it comes to DR artifacts, you can have dead pixels, detector non-uniformity, ghosting or lagging that might happen. Dead rows, you can say image lagging, you can say a bit of another part of it, the ghost image behind, part of body, part of lower limb, all of them together, dead row, pixel, backscatter pattern. All of them are examples of detector artifact or artifacts that might arise due to detector abnormalities. We're still moving and understanding. So what will happen now? We've got detector. So now we have live detector. We're not in the image formation. The image that could be failure with the histogram, with anatomy, large scaling, enhancement, everything wrong anatomy, errors, staging, misregistration, and others. Exposure index also, overexposure automation, but the image exposure index is not same as patient, so it could be more negative, could be positive, it should be around zero, the target. So windowing sometime also. So understand, is it real or abnormality, pathology or artifact? Does it follow anatomy? Consider it pathology. Does it follow? Does it repeat in the same location? Must be detector artifact. It's a thing that is same place, same location. So is it outside patient boundaries? So maybe external, something external. Motion directions, motion artifact. So grid pattern, exposure color, grid, mostly confirm on another view. So if you have something, you will know you get making silhouette with the heart, and you don't know whether it is arises, it is outside or inside the mediastinum. So just take capture lateral view, trying to confirm another view will help you to understand whether the abnormality is real or it is just artifact, it is pathology or artifact. Understand this. Repeat imaging justified only if the quality will help the diagnosis. So remember, quality assurance also is very important. It does not replace correct accusation techniques. Still, there will be quality assurance, but you have to understand the correct technique to capture or accusation of the image, because accusation also has very value. So now we have our source, patient, read, detector, processing, QA. When the image lies, trace the journey, understand the cause, and remember, not everything you have seen on image is pathology. See you in the next video.